All right, welcome to Simulation Pulse. We are joined today by Bill Ballo from Madison College, who runs the XR Center there. We have Rick Castile, our customer experience specialist here at Acadicus. I'm John Bruscio, the co-founder and CEO of Arch Virtual, the developers of Acadicus. And today we have a very special guest. Reed Champagne is joining us from Northcentral Technical College. Super excited to have him here. And he's the manager of health education and technology at North Central and an adjunct faculty in nursing. So really excited. There was an interesting series of events that occurred where Reed is working on building a simulation or a bunch of different simulations that he'll be talking more about, but went through the process of realizing that there was a limitation in one of the environments and gave us some feedback on how we could improve. And we were able to kind of go back to the drawing board, make a couple of changes to an environment that enabled Reed to continue developing the simulation. And that adaptability of the platform is something I'm really proud of and really excited about with Acadicus, where it's about empowering technicians and faculty and simulation experts like Reed to be able to do things and to be able to come to Acadicus and say, here's what we want to do, and then use the tool to create the simulation. So really excited to have Reed here. And I'll turn it over. We can use this time however we want to make, the most efficient use of our time, but I would love to hear more about your background, your vision for this simulation, how this came to be, and how we went about sort of creating it.
Sure, yeah. So first off, thanks for having me. I appreciate the opportunity to talk about this. So this idea originated from actually something that I presented on here last year or last couple months ago or whatever. We hatched the idea to create a fairly robust clinical makeup scenario for our final semester nursing students at NTC here. And we used the 4-bay background scene experience in Acadicus, and that worked really well because it was set up like an ICU. It was set up really well to house for a multi-patient scenario where they had to do it by themselves, right? So initially, the faculty, because that was met with really great success from my end, the faculty and the students really had good feedback for that, from uh, the ability to mimic a clinical day pretty much as possible without being actually on site, compared to the normal clinical makeup assignment that they would have gotten, which would have been like a case study to watch a video with or something like that or whatever, right? But by using a catechus and creating something that was pretty much directly aligned with our curriculum and our learning objectives associated with that clinical rotation, um, we were able to simulate pretty close to what they would have experienced, and of course throw in patients that they probably wouldn't have been able to experience either, as well as tie in traditional sim stuff with a fairly impactful debrief session based on the experience that they had, and it went really well. So knowing that, seeing the success of that one, then of course the other semesters came and like, hey, we want to do that, which is good. So this one that I started working on was for our third semester clinical rotation for our second year students also. And I started doing it in the same 4-bay scene, but I was kind of branching out to see if like, oh, well, maybe there's other scenes that might even further immerse, like having to be alone and prioritize your patients in a different hospital setting. So I knew of, like, I don't remember exactly what it's called, but it's the hospital ward setting where there's the hallways and the doors and everything like that in the lobby. So I knew of that one, and I had played around with that one in the past, trying to build some stuff in there. But at the time, there was like one door that was open that wasn't really supposed to be a patient room. It was like a break room, staff room kind of thing. And then one room that was open that was very long with two doors, but didn't necessarily couldn't hold like a patient room without being really long on the other end or whatever, right? So I reached out, thankfully before I started building too much, I reached out to Rick and some of the other people here about the potential for maybe open, because there was a bunch of other doors. It was set up like a whole unit, right? Then there was a bunch of other doors, but they were just inaccessible. So I reached out and I was like, hey, not knowing if this was a possibility, hey, is there any opportunities to maybe open these doors up and make more patient rooms in here? Because I think I could really make something pretty cool. I thought with more available space, right? So I got a very prompt response from multiple people, and they made it happen in like less than a week. I was really surprised at the turnaround, honestly. So that was cool. Then I was able to start building. So it opened up, I think, like 5 rooms or something, along with the rooms that were already open. And I'll share my screen here in a second to go over it, but um, allowed for a little bit more of a like just a different hospital sense where like not every hospital is going to be set up like an ICU where you have these big large glass doors where you can see in and kind of peep on your patient just when you walk by. Like you might have to go in and it's a smaller room that you have to navigate around, and it's set up differently where you have to be intentional with what you bring into the room. It's not all going to be available out in the open, right? So that was beneficial to that point, and it ended up working out pretty good, which I'll show in a second here. But yeah, the process again, like I have had a fair amount of experience in building an Acadicus to this point, but I don't know really like the back end stuff, like how to change the fundamentals of a scene. So that was nice that knowing that that is a possibility in some scenes worked out really well. So that was good. Did I miss anything about the process there?
No, but
But
I do just want to echo what you're saying, Reed, because oftentimes I'm on the receiving end of customers kind of going, "Hey, Rick, can we do XYZ?" And often in my head, I'm trying to calculate, okay, what's the possibility that we can make this happen? And that was one where I was like, "Oh, I wasn't feeling confident." And so I tossed it over to Sean. And like you said, it was a matter of days, and he got back and was like, "Okay, it's ready."
yeah.
Was like, really? I mean, I kind of stopped what I was doing to jump in and go check this out myself. Seemed like it was going to be more complicated than I knew, but there it was. Like you said, a couple of days later. So hats off to Sean.
Yeah, that was really
Yeah.
impressive, and I appreciate that. So sorry to cut you off, but
No, that's fine. Yeah, and we get, a fair number of requests like that, like Rick said, where people will say, there's things that we want to do, and some things are deceptively difficult to do in VR, to develop. Where someone just wants an animation. Can we have this patient, stand up and walk over there and do this thing with their hands, and then go back and sit down? Well, that's we're hiring animators, we're doing motion capture. That's a very expensive, very complicated process, even though it seems relatively simple. So we can build those things, and we do, but those are always, Acadicus assist services where there's some additional cost, and we discount that in order to share it in the library. And I think everybody's familiar with that by now. But environment settings are something that seem like it's going to be really complicated and really expensive and difficult to make those changes, because in the real world, opening up those rooms would have cost, hundreds of thousands of dollars, right? But those are the types of things that we can do relatively easily on our end. And I don't want to overpromise that we can make, all kinds of environments and changes, but on the bigger scheme of things, in the bigger scheme of things, environment settings, making those modifications is something that we can do very efficiently, and we're excited to do, because every time we do it, it multiplies. It has a force multiplier in terms of it's not just going to benefit your program, but potentially every program now has use of that. And so that's what we like to see. And our background originally was architecture coming into virtual reality. So doing those environments in architecture, that's our bread and butter. So just one message I just wanted to leave there, that if anybody's using Acadicus, if you're in there building simulations and there's a couple of changes to these environments that you'd like to make, let us know. There's no guarantees, but chances are we can make that change for you pretty quickly. So I'll turn it back over to you, Reed. Sorry to take the mic
no,
for a while, but just want to be clear about that.
yeah, that's good information because yeah, like Rick said, I was like, oh geez, I don't know if this is an outlandish request or not or whatever, right? But um, yeah, it really worked really well. So is it okay if I share my screen quick so I can kind of
Please do.
show it off here? So cool. Um, okay. And if it's choppy at all, just let me know. But so let me back out of here a little bit. So this is that hospital setting. This part wasn't changed. Just the big lobby and the reception area and stuff like that. But what was the case initially was, let me get to the rooms here. Um, Initially, it was this door was open, and I don't think this was changed much at all. This is just like a staff room, whatever. And these two doors over here were open, and this was the only accessible room at the time. So as you can see, like you could set this up to be like a like a two-bed room, kind of, because the lights are here and stuff. And truthfully, there's more stuff I want to add in this room yet. I was gonna make this like a common area for a nursing station with some desks and everything. But it wasn't what I was finding was if I made it a one patient room, like I said, there would be a bunch of dead space over here or whatever the case. So there were these doors which are now open, but these were all closed and inaccessible. So what I had thought to do was reach out and say, hey, would these be able to be opened up, knowing that they probably wouldn't be large, which is fine, but be able to be opened up to be patient rooms. So these two were opened up, and then the ones I ended up using were on this hallway for the patients. So this sim is a 3-patient one to correlate with our third semester clinical rotation. So I was able to put all these patients with the room numbers all together here. So just to make it a little bit, I thought about putting patients on the other side too, but I wouldn't want to interrupt like the immersion and if the student had an issue with like functionality in VR. So that's why I opted to put all the rooms next to each other, but still obviously they're all in their own rooms and they have to navigate around to those rooms. And then this fourth room over here, I kind of made like the supply room slash med room. Um, and then I was going to make like a storage room on the other side. I just haven't gotten to it yet. But for the sake of being able to pilot it this week, I wanted to make sure that the meds were there so they could run the sim. So this is similar to how I had it set up in the other one, where I just made like these tables with the medications that are accessible here. There's a couple extra ones that so then the student would need to obviously do their med checks and make sure that they're grabbing the right ones and everything. But the nice thing about this environment compared to the other one is like just like in the hospital, there's a specific room, like unless you're in an ICU where it's an open concept, right? Most inpatient units have rooms where the Pyxis is or the med dispenser or whatever, or the supplies are, and you have to then traverse into there, make sure you know what you're going in there for, so you're prioritizing, and make sure you are bringing the right thing out so that you don't have to go into this patient's room and then be like, oh, shoot, I need to leave again. And that's wasted time and efficiency and whatever, right? So that was a good option that I didn't have before, was having a dedicated room. And then, I mean, each of these rooms are pretty similar to each other. I have the patient monitor up here. Something I did differently this time was instead of having a little table with the socketed return equipment like the blood pressure cuff, stethoscope, O2 probe, I found this in the assets, which I didn't realize, and I didn't realize that you can make the individual parts grabbable. So this worked out a lot better. And I think I had to do something like this because the rooms were a little smaller versus having something in the corner over here. And this worked out really well because then the student, all they had to do was position themselves here, grab something, and turn around, and they didn't really even have to teleport, which was a really nice portion of that. So I tried to make everything that they would need kind of on this left side. So then the chart with the orders and the MAR would be on this side then. So just because, there is a little limitation with the smaller room that they wouldn't have to go crazy and go like over to this corner and then over to this corner and stuff like that. And that seemed to work out pretty well, even compared to the first 4-patient one I made. So it might have even been better that the room was smaller just because there was less ability for them to get stuck over in the corner or up in the ceiling or whatever they do. Um, so yeah, the premise of this sim was similar to the concept of the first 4-patient one. I basically split it up into 3 stages. Whereas the first stage, they're coming onto their shift, they have to do their initial assessment of the patients. And then while they don't have to tell me, just like in clinical, they're going to go do it and see who they're going to see first, and based on their prioritized thoughts, and do it. And then we talk about it in debriefing. So I tell them that right away, like, I don't want a narrative of everything you're doing. I want you to do it, and then we'll talk about it, right? So the prioritized person in this first stage is Malcolm here, and he's actually one that I used in the fourth semester one. He was just at a later stage, like he was ready for discharge in that one. Whereas this one, he's coming in with acutely diagnosed type 2 diabetes and hyperosmolar or hyperglycemic non-ketotic syndrome. So he's the acute case right now because they have to start an insulin drip and make sure that he's stable because he just came in like 30 minutes ago or whatever. So the report that I give the student then is minimal. So they need to go and see them. This person here had a robotic lobectomy yesterday or post-op day one. So they got a chest tube. So they have to incorporate stuff about that because this is in third semester. That's when they really hammer down chest tube concepts. And then another, arguably, in my opinion, more important aspect of this patient is that they are on the lung surgery was a palliative approach because they have metastasized cancer. So this forces the student to then uh, apply and demonstrate their soft skills in talking to someone who needs to have a potentially hard conversation with, they bring up like, well, am I just going to go home and die? Or, I have family calling me over and over. So it really brings to light some of the soft skills of therapeutic communication that students either shy away from, avoid, or don't really get a chance to practice in mannequin sim or in clinical. So this patient was actually kind of the highlight of our debriefing process because, some of those hard statements that nurses have to deal with in the moment, right, really froze the student that piloted this. So not that that was the goal, right, but they told me afterwards, like, I've never been in that situation, nor would they probably have been in clinical. So I was really pleased, and we had a therapeutic communication kind of focus on one of our patients in the previous one too, but I thought this was an important one to include. And then this one comes in with a UTI, but she has a history of bipolar disorder and hasn't eaten or drank for a couple days, so she's missed her lithium medication, and the med rec wasn't done by the previous nurse on admission. So after the initial assessment, the student goes and does other stuff. And then in the second stage, she develops acute mania because she hasn't had her psych meds for some time, right? So then they have to work on de-escalating with a mental health crisis, I guess you could call it. Considering like, well, when do I call the charge nurse for a sitter? Or, I need to call the provider, and it's an opportunity for them to use an S bar and stuff like that. So, in the midst of having someone on an insulin drip and having to check their blood sugar every hour and stuff like that. So I was a little hesitant on having, two pretty labor intensive patients at the same time. But again, in clinical, even in fourth semester, like as a student, they're not really the sole manager. Like, yes, they're taking care of the patients by them, 90% by themselves, probably, right? With the oversight of the nurse and the faculty, but they're not really getting that true experience of, well, this person I have to stay in here because maybe they're a threat to themselves at this moment, but this person is on that insulin drip and I need to get that blood sugar every hour, right? So what do I do? Am I calling for help? Am I, delegating this to another nurse to go get the blood sugar and stuff? So that was a good talking point of our debriefing process as well. But like I said, at the using this scene as it previously was, these were all blocked off. So I wouldn't have had the opportunity to make an experience like this in this scene prior to, reaching out and having them alter it. So that was good. Um, any questions on the scene itself?
No, this is fantastic. Covered it really well.
Cool.
I
Um,
think
I'm
one of the
just
things
curious, how do
oh,
you pre-brief the students? Like, you gave us a lot of history about each of those
Mhm.
patients. How do the students get that information prior to going in here? Or is there something they get once they're in the scenario?
Yeah, so I actually have the documents up in a different tab, so I'll pull that up in a second. But some of the stuff that they get prior is are these exact documents that are up on the wall here. So, in the packet that I give them prior, they have the orders, they have the MAR, they have the H&P, which I didn't put in the room because it would have taken up too much space, I feel like. So yes, they have a pre-briefing. I tried to make it like clinical as much as possible. So let me 1 second here, share my other screen. Um, so this is like the template that I would use from a facilitator standpoint. Um, and I try to create this, and this is still a work in progress to a point too, that anyone could jump in and with knowledge of Acadicus probably and facilitate this experience. Because right now, our faculty are fairly hands off with VR and Acadicus and stuff, which is why I'm in the position I'm in. Um, so I take the reins and I facilitate all these because I have my MSN and I can evaluate the students in this setting as well, like from a clinical standpoint. So, um, but to answer your question, so I have documents for every patient. So for their H&P, um, I tried to set it up just like one would see in a chart in a hospital, right? So, their chief complaint, diagnosis, general previous assessment, and I tried to make these off of like the admission so that this didn't give them absolutely everything they needed. Like they still needed to prioritize their own thoughts, right? Um, and to not make it extremely long because I can't just have them prep for 2 hours for a 45-minute simulation or whatever. So, but I tried to include generally as many things as were relevant that they would see in the hospital for the H&P. So like this is their starting point. So just like they would in clinical in real life, they would go in and they would look up their patients for the first 20 or 30 minutes or whatever, wherever they're at in their progression, right? And then they get reports. So I give them the chance to look at the H&P. Like I said, I have the MAR, I have the orders, and once they've looked up their patient and created their brain sheet and stuff like that, then I give them report based on as the offgoing nurse outside of the headset, so in real life. So like this one is really short because he just came in and they didn't even finish the admission yet. Whereas, let's see, this one should be longer. That is not what I wanted, sorry. Report. Whereas this one's a little longer because I need to give the background of her surgery and what's transpired since she's been on the floor and stuff like that and whatever. So that was, and this worked really well with the previous one I made, because I really wanted to make it like a clinical day as much as possible within my abilities. This forces them to look up their patient, you know, utilize what I give them in report, and I don't always give them all the information in report intentionally because they're not going to get a perfect, pristine shift report every time they go to work, right? Sometimes they're bad, and then they have to go and figure out what's going on with the patient. But uh, not that I'm trying to trick them or anything like that, but like, you know what I mean? So,
It's
um,
just the real world, right? We're trying to make it as real world as possible.
yeah, so they have the opportunity to look up each patient. I give them a report on each patient, um, and they write down their little notes and stuff like that, and then they hop into the sim. So it's just like they're just coming onto the shift. So yeah.
Really appreciate this because one of the gaps that sometimes occurs with organizations and teachers, educators, is we could teach them how to use Acadicus and do a sim, but then they kind of can't figure out how to fit everything else in around it, right? Like, how do I start? How do I end?
Mhm.
And that's where they get stuck. It's like, okay, you've shown me how to do this when I'm in here, but now how do I wrap my whole session around this experience in the headset?
Mhm.
And so it's great seeing this. I mean, it's really helpful.
Yeah.
One of the things I really love about the platform is that ability to take the imagination, right? So you start to think about something in your head that you're looking to do for, whatever it may be, nursing in this case, EMS, dental, whatever it may be. And you kind of go, okay, now I can form that with all of the equipment. Like you said, oh, I didn't even know this was in here. And then I
Mhm.
grabbed it and I put it in and I realized all of that stuff was grabbable. And so you can kind of create all of that within the space. And that's one of the things I've always loved doing is being able to just write out a scenario and then go, I can go and build a lot of this in there. There may be things like I may have to come to Rick or somebody and go, is this in here?
Yeah.
And where, by the way. So, I may have to do that every once in a while, but the creativity. I really like the creativity with it.
Mhm. Yeah. Yeah. And it's, again, like, with the facilitator sheet template thing, I tried to make that as so it would be as repeatable as possible. So like a sim, like we want those to be consistent and the student to get the same experience every single time, regardless of who's facilitating or operating the sim or whatever, right? Um, so I think it's easy right now because I'm the only one doing it, facilitating. If we had more hands in the pot, I think it would be a little tougher, which is why I try to, I apologize for sharing and unsharing so much, but what I try to do is like include dialogue that the patients should be saying that would sway the student to do this action or do that action. Now, similar to somehow how some of the OER sims in the library are. They're split up into stages with a general outcome, and then what the student should do as far as like an evaluation standpoint, versus what could happen with the patient if they do this branch or they do that branch, right? So like for example, if I um, let's see. So like this Malcolm, he's the one that comes in. He just found out he has diabetes. He's in this acute state of health, right? He's just got admitted to the hospital. So he's angry and he's frustrated and he's scared, right? But if the student doesn't address that, he's going to continue to be angry and frustrated and scared toward them. Whereas if they, empathize with the guy and say, hey, I know this sucks and I'm sorry. We're going to do our best to take care of you and explain things, as we go, and then he'll say, okay, well, I'm sorry. This is more stressful. Uh, I'm mad at myself for putting myself in this situation. So there's branches that it could go, right? But I tried to do it like, in general, this is what they should do with this patient at this stage. The main goal of this stage for Ruth is to give her IV antibiotics. The main goal here is to assess the chest tube and assess the patient. And I think there's a medication to give for this person. And then Malcolm, of course, should be the first patient seen because he's the most acute one at that time. And you have to initiate the insulin drip. So as you go, what I'm seeing and trending in myself when I make these is that stage one is like initial assessment, potentially like a task. Stage two, one of the patients has a changing condition and they have to respond to it. So the previous sim that I made, the fourth semester one of them develops flash pulmonary edema and they have to respond to that and call rapid response. And then they end up getting transferred to the ICU. Whereas the change of condition in this one is with Ruth, where then she outwardly has the symptoms of mania and they have to keep the patient safe, de-escalate, call the provider, use an S bar, be efficient in that sense. Um, Whereas with Anna, the patient in the middle, nothing really happens with her because she's on the phone. And the reason I did that intentionally because the other two patients kind of have a lot going on in this stage. So um, yeah, so that's that. And then stage three, Ruth gets lorazepam and she calms down. This stage three is where they have the difficult conversation with the patient with cancer. And then Malcolm, they just have to titrate the insulin drip again. So once they get Malcolm settled in the beginning, it's really just checking his blood sugar and titrating the drip. It's not as, you know, emotionally intensive, whereas the other ones kind of shift to that. So, um, yeah. But one challenge that when I was making the first one was like, how much information do I put in the room? Because they need to have the MAR in the room so they can do their med checks. And then I was like, well, they probably should have the orders too. But I didn't really necessarily want to put a whole history and physical in there because that would take up 3 or 4 slides on the image displayer. And then they might be fixated on the wrong things because this is a snapshot of when they first came in essentially versus where they're at now from what I told them in report. So, yeah, that's and I like I said, I got really good feedback from the students in the first round of last semester when I started doing this. And after last semester, I realized like obviously I had a verbal um feedback, but I should probably be capturing this in some sense to be like, hey, this is impact and an impactful and meaningful substitute when necessary for clinical, right? So I was able to create a form like a post survey essentially to capture some of this stuff. And I'm just going to distribute this to them after they complete their experience, mainly for the clinical makeups. I don't know if I'll use it for like the general sim days when we just use one of the shorter ones, because I think the goals and objectives are a little bit different when talking about those versus a clinical makeup. You know, there's a lot more weighing on it. So I tried to make these questions targeted and intentional. Like, hey, so did this serve its purpose? Did this mirror a clinical experience that I would see or that I have seen? Right. From the and something that I felt was important was getting their perspective of the situation, not just like a, hey, did you enjoy this? Yes, no. Like, no, like, do you feel that you improved based on doing this experience where prior to the patients that you took care of, the chest tube, the cancer, the DK or the HHS, the whatever, right? You know, how confident were you in that before? Because they probably haven't taken care of 3 of the 4 or 2 of the 3 of those patients yet. And how confident do you feel after, right? Um, and then again, kind of getting their perspective, like how do you feel you improved? Because I can say how I thought you improved as the evaluator or the assessor, right? But I also want them to have stake in the process. Like, do they feel this was beneficial and impactful that they improved, right? And then also some long answer, like, tell me how you're gonna apply stuff from this experience to your practice or to your student practice or whatever, right? And then also, of course, like how could it be better? So, um, I I finished this summer, and then we're gonna roll it out for our next batch of students that do the experience. I did it with the pilot student. I don't think I've gotten a response yet, but that was Wednesday. So yeah.
I was so glad to see the survey. I think that's one of the most important things in building, especially demonstrating the value of what you're doing to other faculty, to your administrators, to give them the bigger picture of, students are enjoying this, not only enjoying it, but they're actually gaining, from it. They're benefiting from it in a significant and measurable way. And I think that's something we encourage every program to do that, because I think a lot of programs are in the same boat where not every faculty member is using it, and there's someone like you that's kind of the champion or the XR coordinator like Bill is, and just when you're in it and running it, you see the students' reaction, and you see how they're learning and improving, and they're engaged and they're into it. But if not every other faculty's in the room watching that happen and they don't see that with their own eyes, it's hard to imagine. But with that data you'll get from those surveys, that's really important to be able to continue growing the program. So we definitely encourage every program to do that. I think that's great. Overall, I think the simulation feels like, to me, even in just hearing the description of it, it feels very real world to me. Like as you're describing it, I'm imagining a hospital ward where there's these things that are happening, and I can imagine the stress that the nurse is feeling, and the decisions that they have to make, and how that would weigh on them, and how do they make those decisions, and putting them into that situation that's so close to what they're going to experience in the real world. That's fantastic. And I think it's a great use of VR. One question I wanted to ask you is, in terms of your role at North Central, Or I mean, actually, that's my second question. Then the first question I want to ask is, why a makeup? Why a clinical makeup? Why use virtual reality for this use case? And we've seen this in a number of programs that use this for a replacement. And I'm curious, what's the value there? What's how does that kind of compare to the alternative of running this with a traditional sim?
Yeah. Well, I think first off, it's probably a little bit more accessible than a traditional mannequin sim. Um, I mean, I could step into a mannequin sim too and run that, right? Um, but it's a lot harder to get three mannequin sim patients in a room and facilitate it without 3 to 5 people, right? Just operating, and then also having to have someone evaluate on top of that, right? So I think accessibility is a pretty huge thing there, um, but also I think obviously there's going to be some limitations. Like there are some medications that maybe I wanted that weren't there, or some of the assets that I have to put in certain places versus not, whatever, right? Um, but I think the ability to, like I said, focus on some of those soft skills that I think, when I teach clinical, it's usually the 4th semester students, so right before they go to practice, right? And something that I've seen either in the students that I've had or the students that I have had that are now nurses is that the thing they struggle with the most is talking to patients, connecting with them, and then, unfortunately, some of them develop those biases that we have with certain patient populations, like Ruth. If some nurses see a history of bipolar disorder, they automatically go, "Oh, well, she's going to be annoying and take up all my time and whatever," right? Just because there's a history of a mental health disorder without knowing anything about the patient, right? Um, so I think using VR experiences like this, um, you know, allow for more meaningful development and practice in those areas, whereas uh, mannequin sim might not address those as much, and especially not like traditional makeup, like, hey, go observe a sim and sit in the control room and just write up a little thing about it or whatever, right? Or do this case study and complete this paperwork or whatever. Like I think there's a way more meaning. Of course, we don't have the objective data until we get some of the stuff from that survey, but based on the feedback that I've received from the students and the faculty, I think it's pretty obvious that the meaning and the impact of a VR sim like this is far and above what else we've provided. So, and then like you said, it's we can get it. Obviously, nothing is really going to beat real in-person clinical for skills for overall development as a nurse or a professional in any health setting, right? But I think so far this is probably as close as we can get. So to mimic that experience. So yeah, I think that's why we've opted for that.
Yeah, that's great to hear. And I think, one of the things, we're way out on the frontier here, right? This is still a very new world that we're entering into, this virtual dimension, and we're running simulation. And I think, in the early days, we saw the VR headsets, we saw how realistic the environments were. We knew simulation it would benefit from this. And we've been sort of, as an industry, as a simulation industry, as VR developers, we're working together to build these tools, but we still have hurdles, right? And the hurdles are like getting people familiar with virtual reality. That's the first step. Right now, we don't have as much of that because most everybody's at least had some experience with it. Whether they're using it or not is still kind of to be seen. But everybody kind of has a sense of what VR is like. And then it's the convincing them that it's a serious tool that you can use for simulation. It's not just a video game. That's the next hurdle. So there's these hurdles, but one of the hurdles that I think that we're most up against right now is organizations struggling with how to implement it and how to get their faculty on board when, for the most part, they're already short-staffed, they're already very frantic, they're very, very busy, and they're not necessarily interested in learning something new. And one of the ways that we frame this is that we're trying to build software that allows you to do sim the way you already do. We don't want you to have to learn a new tool. Once the environment's set, you can facilitate it in much the same way you would a traditional mannequin sim, but there's still a very, very real and measurable value of having someone like you on the team that's responsible for building virtual reality and implementing and facilitating these, much like Bill is doing at Madison College. And so the thing that I'm thinking a lot about is how do we convince other programs that even though it's tough to sort of assign that to someone and give that extra responsibility, now we're doing something new at a time when we're already really busy. But if you make that investment, you're able to do so much more. And it actually ultimately frees up time and it frees up faculty time and provides new resources. So I don't know, that's a whole long way of saying, like, I really think it's important for programs to have somebody that is the facilitator, that is the dedicated XR person. The programs that we see implementing VR that have that always do better. They're the ones that are saying, next semester we're going to double this program. Our students are happy. We're getting surveys. Those are the programs that are succeeding the most. Whereas other programs that just buy it and, just give their faculty access to it. Here you go. Start doing VR sim. It's hard. It's hard to get people excited. So your role at North Central, I think, is really important. And I wonder if you had any thoughts about how other programs might think about creating a role like you are, like what you're doing there.
Yeah. Well, and that brings up an interesting point because before I was in this role, not saying that this was created for me, but this role didn't exist prior to me having it. So, and trying to be transparent, we had Acadicus for a bit before I was in this role, and we really weren't using it that much, honestly, because of that exact example you said. Like the faculty, already have however many instances of load, right? They have theory class, they have multiple sim sections potentially, they have clinical sections, right? And so not only from a load acuity standpoint, they were busy, but also it was like intimidating to them because it's a whole new thing, right? Just like, if like we're seeing with AI right now, like people are nervous to use it because of whatever, right? Because unless they get adequate and appropriate training. So, I mean, yeah, I think we're really fortunate, not like speaking myself up, but in general, like we're fortunate to have a position like this here. Otherwise, I don't know if we would be even utilizing a catechist the way we are. Um, Now, one of my main challenges so far is getting other programs to be on board because nursing is kind of just mainly the one utilizing it. And I know a catechist has, serves other purposes with RT and, potentially surge tech and stuff like that and whatever. So, EMS. So that's been my main hurdle. But yeah, I mean, I think it helps from my perspective that I have the nursing background myself and my master's in nursing education. So, the faculty can come to me and with like a pretty broad, vague concept, and I can kind of piece it together with or without their help. Um, Whereas if someone with like strictly a tech background would probably struggle, if I'm being honest. Which the job description would have to obviously reflect what their background needs and their job is going to do. But like for example, I went to a sim conference this summer and talked to other people who had VR and everything like that, and it seemed like whether it was a sim tech that was doing it or the sim ops person that was doing it with the VR thing or whatever, um, most of them only had tech experience. So I don't know, Bill, I believe you have EMS background.
Yeah, you have to have, but there, I don't know that it's absolutely necessary that we have someone who's medically trained. It's extremely helpful.
Yeah.
It's extremely helpful. If you have a good subject matter expert that will kind of come along with you. So that's what I've kind of figured out when it comes to things like architecture, which I have no experience in. We have HVAC technician. We have all these different programs that are now utilizing virtual reality, and I know really nothing about them. I mean, Spanish language learning. I don't speak Spanish. So what I wind up becoming is the person that helps with the hardware and understanding how to use the software. So you know, I wind up doing instructional design. I wind up sitting down with them and saying, okay, what do you want to do? How do you want to do it? And then figuring out how we're going from there. And that takes some of that tech knowledge, And then, most of where people launch this is they launch it in nursing and they launch it in simulation, or they launch it in healthcare, I should say, and they launch it in simulation. And so, they look at it as a sim tool. I originally looked at it as a lecture tool, as to bring it into my lectures, and now I'm finally getting faculty that are going, oh, I could use it that way too. And you're like, yeah, they're like, oh, so instead of just having, the case study up on the board and having the student try to imagine this case, I can give them a real tactile thing to see, to look at, to feel, quote unquote. And so yeah, it's you have to have a person. And John, we've talked about this multiple times. Rick and I both have talked about this multiple times with multiple places. You have to have a person that is going to help to implement this. Having that training in nursing is amazing and helpful. In EMS, amazing and helpful. You have to have somebody that's willing to sort of pull others in. And we saw this with simulation in the early days when we first started doing mannequin simulation. And I can't tell you how many instructors would be like, mannequin simulation. Oh, please, that's not a replacement for going out and doing all that clinical work. They got to get out there and do 300 and some odd hours in the field, and and that their simulation can't replace that. And now we would laugh at those people. We would go, yeah, yes, it can. We know it can, right? And so that's the same thing that's happening with VR right now.
Yeah, and I think it's while we're on this kind of frontier that it's going to be most important. Like, I think we'll get to a point, just like with Mannequin Sim, where we've developed best practices and standards and norms and expectations within the industry that start to percolate. And then it's easier for a faculty member to run it because you've already got this playbook. But right now, there is no playbook. This is a brand new, wide open frontier, which is what makes it challenging to implement, but also thrilling and exciting because it's opening new doors that weren't otherwise possible before. And so I think it's really unlocking new things. But right now in this transition, as you're defining a new category essentially in simulation, you're bringing all these wonderful things into this virtual dimension that then unlocks all these new possibilities. You need somebody to guide that. You need somebody to own that in the program that can say, I'll take this up. I'll figure out how to use it. We'll develop those playbooks, and then we can start including other faculty. And that is really the next step. I was talking about kind of a lot of the programs that are reluctant to assign a faculty to somebody to build these things the way Reed and Bill do. But once you do, once you're doing it, I've seen this happen at Madison College with Bill, where you go in and you sort of like run the first batch of it, but then the faculty's there and you see the faculty saying, you know what, I want to do a 3D recording. I want to put a headset on and do a demonstration of this veterinary, simulation or whatever. The faculty start to see that, and it has a gravitational pull. So I think it's not just about you're always going to need somebody like that, but it's right now you really do, to just set the stage, to get the standard set, to build those playbooks, and then start bringing more people in.
Mhm. Yeah, I agree. And I mean, truthfully, I think there's other colleges in the WTCS system that probably have VR and they're in the same boat that we were before 2 years ago. Like they're just not using it. Um, so yeah, I it I hate to say it's like needed, but yeah, it's probably kind of needed to have a position similar to mine or Bill's.
And I
To it,
even found
yeah.
how important having a place was too.
Yes.
Originally I had, like, especially with architecture, originally they were kind of like, no, we just want our own area. We want our students to be able to go into our lab and do their work and not have to worry about coming to the XR Center or making any appointments or coming in certain hours and those kind of things. And now that's kind of done a 180. One of the instructors said to me, we're not using it that much. We're not really, like, it's collecting dust upstairs. Like, and we come here and everything just works. Like, up there we had to, oh, why isn't this working, or why isn't that working, or I'm having a problem with this, or I'm having a problem with that, or the meta headset doesn't connect correctly, or the HP reverbs are no longer available, or something like that, unless you download this certain software. So there's got to be somebody that's up on that. And just giving that over to faculty and saying, here's equipment, figure it out. No way. No way. And the instructor in architecture, like, he is probably higher up than me on the technological knowledge scale. But when it comes to making everything work the way it's supposed to, he's just like, it's just much easier to come here. And we just bring our students here. And so we're actually going to set up, hours specifically for them in the XR Center. And then the students can come in and they can do their work. And they don't have to worry about trying to figure out, did this work, did that work, those kind of things. So
Absolutely. Well, and I think too, once we get these programs, like you're kind of leading the charge, right? Madison College, North Central, and other schools that have taken that up and are able to demonstrate effective use of the software, that they're starting to see return on investment, and they're building and growing these programs. I think one of the important things to think about in virtual reality is that geography is irrelevant. It doesn't matter where you are. It doesn't matter where you live. And it's no longer necessary for someone that's an expert to be geolocated in the same place the students are. And a vision that I have is that someday maybe there's a WTCS XR statewide coordinator, right? Like, you guys could both help other programs, which is part of what the Pulse is and part of why we want this community of practice, to make those connections, because you can compare notes and say, hey, we just tried this thing and it worked really well. Did you know that you could take that thing and the blood pressure cuff is grabbable? Like, those are things that you just don't know until you're in there. But you don't have to be in the same classroom anymore. Like, once you're in the headset, you could be hundreds of miles away. So I think sharing resources, and we're using Wisconsin. I think Wisconsin is definitely punching above its weight in the implementation of virtual reality and medical and healthcare simulation. It's just remarkable. And someday I want to tell that story too. But as the statewide program continues to grow, maybe we'll see some of those shared resources, and that could be a model for other states too, because we're not the only state that has shortages that are coming down the pike that are pretty serious, and they're getting worse, and we have to have solutions for it. And I would like to think that virtual reality and Acadicus could be part of it, and sharing those resources could help build those programs in other states as well. So yeah, great use case here. Really appreciate you taking the time to meet with us. This has been fantastic.
Yeah, of course, I appreciate the like I said, the opportunity to do so, because like I said, it's been met with pretty good success from our students. So if you're not using VR in this type of method for clinical makeup, or even sim makeup, or whatever the case is, I think it's a really meaningful way to do it if it's developed correctly and facilitated appropriately and stuff. So yeah.
Thanks,
Absolutely.
Reed.
Any other questions, Rick, Bill? Anything left unsaid?
not for me.
All right. Well, thank you so much for joining us, Reed. This has been fantastic. Very inspiring, exciting. I can't wait to get this out as an episode. We'll share this, and yeah, thanks again. We'll see you. We have guests coming throughout the fall semester. We're getting the lineup set up, so stay tuned. Every Friday at noon Central, we're going to be recording one of these. So thanks for joining Simulation Pulse Live. Thank you very much, Reed. Thanks, Bill. Thanks, Rick. We'll see you next Friday.
See everyone. Take care.
Bye-bye.